I do see some familiar faces, so I know some people this is not new information. But just for my own purposes, how many of you all in here, this is either your first workshop or the first information that you've had on cortical visual impairment? Okay, good. That makes me feel better because I really hate to think that I would be going over the basics for everybody who's already had it before. So hopefully, even for those who've had it, even for those who are well educated in this topic, who could probably be in my shoes, who are sitting in this room today doing this workshop instead of me, I could start pointing out some faces who would do an excellent job. Hopefully people will take something from it today that can be beneficial with you and the children that you work with. I'm not going to focus a whole lot in interventions because that's not the purpose of today's workshop, but I did, as you can see, sitting around the room, try to bring a variety of things that I use with the children that I work with, all the way up to young adults. I do have some young adults that I work with as well. And as I go through different topics that we discuss throughout the day, try to point out some different things that might apply to those areas. So even though we aren't talking about interventions, that you'll get some ideas from that as well. And please feel free when we do have breaks, when we are on lunch, pick it up, play with it, handle it, do whatever you want to. It's not here just to look at. It's for your all's use to take hopefully the best information you can from the workshop today. So before we get started again, how many parents do we have? I know we had some parents in the room. Yay. How many teachers of the visually impaired? Yay. How many classroom teachers? Ancillary service providers such as PT, OT, speech. Okay. Psychologists? Have I missed anybody? Okay. Gives me a good idea of what the audience is as we talk. Also, I like to have interactive workshops, although I will say during the first part, this first section that we go over, because we are recording, if you'll limit your questions to when we finish this section, then we can address the questions. But when we do part 2, I encourage you to interact, share stories, ask questions as we go. Anything that you have that could be of benefit to anyone else in this room, please share, because your all's knowledge base is very vast as well in this room, and that would be great. I hope that we will stay, well no, I'm not hoping that we will stay on our timelines, so regardless of what happens along the way, we'll get through what we can get through, and we're going to finish on time this afternoon. So there are 2 types of visual disorders that we refer to when we're talking about our children who may or may not have cortical visual impairments. We have ocular disorders where the pathology of the eye is directly impacted. Some examples that you might come across in the classroom might be detached retinas, underdeveloped optic nerves, ocular albinism. I have a 2-year-old that just recently became familiar with where I live, who is getting ready to have his second cataract surgery at 2, so his vision is already impacted as a result of that. So when we refer to ocular disorders, those are the types of disorders we will be talking about. Then there are neurological disorders where there's impaired or reduced vision due to an impairment or injury to the brain. Some examples of conditions that might occur with this would be periventricular leukomalacia, where the brain tissue is replaced with fluid-filled cysts. We might be talking about any anoxic episode a child could have, either before or after birth, where there's a loss of oxygen to the brain. We could be talking about an interventricular hemorrhage or a brain bleed that occurs before the child is born, or a stroke that they have after birth, whether it be immediately after birth or farther along down the line. We could be talking about trauma, which results in an anoxic episode, a near drowning, motor vehicle accident where there's a severe injury. So there's a whole host of things that could be a causal factor in a child developing cortical visual impairment. The thing that you need to remember is that CVI is a neurological visual disorder, and it is the fastest growing diagnosis of visual impairment today. Cortical visual impairment is when the eye works fine, but the part of the brain that interprets the information from the eye does not. And at this point, I'm strictly talking about if we're talking about only cortical visual impairment. We're not talking about a secondary ocular condition. The brain has difficulty seeing or interpreting or understanding what the eye sees. When a child has CVI, they will often have a normal eye exam or an ocular eye exam, which does not explain how or why the child is seeing the way they are. Keep in mind that there could be some exceptions. Just a side note, the American Printing House for the Blind is a website that does have some excellent resource information on cortical visual impairment right now, so you can access that on the web. I think it's www.aph.org, I believe. One thing that I always encourage teachers, families, practitioners, whoever is working with this child, that I think tends to often fall by the wayside when a child transitions into the school system is the presence of that medical information. I think as parents, if you can provide the teachers, the resource personnel who are with your students, any historical medical information for that child, it can be a huge asset. Because not just with CVI, but as with any other issue that impacts the brain, the more a team knows about what's going on with that child, the better capable they are going to be to serve that child. So if you have a child show up in your classroom and you know they have CVI, but you don't really know why, that really, in my opinion, can impact what you do with that child. Because if they do have a secondary brain injury, then you may have other issues that come associated with the child that could impact their learning, not just their vision. But I think if you have that historical information, it's very valuable to you as a teacher to know what the etiology is that's happened all along the way. It's kind of like a puzzle, and that's just a piece of that child's puzzle that makes them up. And it really can give you a lot of insight into what's going on. Another reason why this is important, which I don't think I talk a lot about in the first part of this, is acquired CVI versus a child that's born with CVI. And the difference is that when you have a child that has acquired CVI, very often they have been born with normal or typical, whichever way you want to refer to it, vision. A good example are two children that I've seen recently in the last couple of years. There was one little boy who I worked with, had the good fortune to evaluate. He was in an automobile accident when he was 2 years old with his mother, and they went into a lake. Up until that point, he was a typically developing child. And unfortunately, they went into a lake, and he was a near drowning victim. The mother and the sister, they didn't survive. The little boy was underwater for a very long period of time. But they resuscitated him, and he has a number of issues facing him throughout the rest of his life. But the difference between that child and a child who's born with congenital CVI is he had 2 years of visual references in his brain of which to draw upon. And when you're working with a child that does have some visual history, that can impact how they perform and how they do in their progress because they have some frame of reference. It may not be a huge frame of reference, but it is a frame of reference nonetheless. Another little girl I worked with, typically developing child, developed, I can't remember what the condition was, but she developed toxoplasmosis. She got toxoplasmosis, and they had to put in a portacath. Her portacath became infected. She was 2 years, 9 months old. 2 years, 9 months, once the portacath became infected, she threw a clot to the brain, had a massive stroke, and as a result, acquired CVI. But again, that child had 2 years and 9 months of references, whereas a child born with CVI didn't have that information. She knew what colors were. She knew what a ball was. She knew what some animals were. So when it came time to work with her to start building upon the basis that she had, she actually demonstrated progress a little bit faster than a child who had acquired CVI, who you really have to start working with to help them begin to develop frames of reference because they don't have any. When a child is born, they don't know what colors are, they don't know what shapes are. You have a blank slate to work with, a clean slate, so to speak. But in terms of vision, that's not always a positive thing. Sometimes that's a big challenge. This is a picture talking about the visual pathways of the brain. And what you have here is you have a representation of the eyes and the two halves of the brain. Each eye is like a camera, for those who may not know the medical pathology, and each eye takes a snapshot of what someone is looking at. You have two images that go into the brain, and the brain takes those two images and combines them into a single image once it hits the cortex. When a person who has cortical visual impairment is using their vision, the process is exactly the same. The eye still takes the same picture. The image is still transported into the brain the same way, unless you have an ocular condition that may be impacting that. But again, we're not talking about ocular conditions at this point. But what happens is once the image gets into the visual cortex of the brain at that point, that's when it has its problems. It has difficulty interpreting that information. I've seen many parents who say, my child can't see. And it's quite an enlightening piece of information when you talk to them and you say, actually, your child can see. Your child can see the same as you and me, unless there's an ocular condition. The difference is the child's ability to interpret the information that they're seeing. So it's not that they can't see, they just don't know how to interpret it. How many people have seen a Where's Waldo book? Everybody seen a Where's Waldo book? Those are very, very, very busy pages with Waldo. And I'm sure at some point going through those Where's Waldo books, you've had difficulty finding Waldo. You've been able to pick out other pieces of information, other items in the pictures on the page. You can find other little people, you can find food, you can find balloons, whatever the theme is on that page, you can pick out that information. But for whatever reason, you can't find Waldo. It's not that you can't see Waldo, but for whatever reason, at that moment in time, your brain is not disembedding Waldo from the rest of the picture. Your vision is not impacted, you can still see it, but for whatever reason, you can't find the detail to discriminate Waldo from the rest of the page. That is a pretty good example of what CVI is like. Their world is Where's Waldo. The problem is everything is Waldo. And if they have no frame of reference on what they're looking to find, then they're constantly searching for the Waldo in that very, very busy picture. And they can't ever find it until you give them the tools and the capabilities and the skills to do that. So hopefully that gives a better perspective. It's not that they can't see, they can, unless they have that secondary ocular condition. It's just that they can't disembed the information. There are 3 indicators associated with cortical visual impairment, getting a diagnosis, typically. One is that they have a normal eye exam or the presence of an ocular condition which does not explain their visual functioning. They have a medical history to support it. So if you have a child, that's another reason why it's important to look at that medical history. You have a child who comes into your classroom or a child that's on your caseload, they don't have a diagnosis of cortical visual impairment. But their diagnosis does not explain what you're seeing in the way this child's vision is performing, what they're doing in school, why they are the way they are. So looking back and doing some investigative work looking at that medical history might be of real value to you and your team in looking at, is there more going on here than we suspect? So if you get that medical history and you see, oh, this child had an interventricular hemorrhage at birth, and it was a grade 3 interventricular hemorrhage, which is a pretty significant interventricular hemorrhage, that might give you cause to talk to the family and say, you know, when's the last time they had an eye exam? Who are they going to have their eye exam? Has this ever been discussed? Has the doctor ever mentioned this? The third thing they look at is the presence of the unique characteristics associated with cortical visual impairment. And we're going to discuss those later on today, what those characteristics are. Now I have to kind of go off a little bit on when we were talking about number 2, talking about getting the child's eyes examined. It's very important when you look at having these children's vision checked that you get them to a qualified professional. You all are at an advantage in this part of the state. You have the WVUI Institute right here, and that's fabulous. In Princeton, where I live, sending a child to one of our local ophthalmologists is not the same. Not that they're trained, qualified professionals, they are, but their area of expertise is not in cortical visual impairment, and it's not in pediatrics. And pediatrics, even though you'd think the eye is the eye is the eye, it's really not. Pediatric ophthalmology is a very specialized area, and you really need to get these kids into someone who knows what they're looking at. And we've had several instances where for travel reasons or for other reasons the family's chosen to go to someone locally at first, and sadly the information they received was not very good. And ultimately, after some time and going and getting a second opinion, things work out well, but I can't stress the importance enough of getting them in to see a qualified pediatric ophthalmologist from the beginning. Now, just to touch on these, and we'll go in depth in these as the morning goes on, characteristics associated with cortical visual impairment. These are the 10 things that we look at when we look at whether these characteristics are present to help support a diagnosis. I will say none of the CVI mentors, none of the TVIs, none of the parent, there's no one who can give that diagnosis of cortical visual impairment except for an ophthalmologist or a neurologist. Even your doctor can't do it. They can suspect it, but they can't diagnose that condition. They are not qualified, nor am I. I can tell you whether or not the characteristics are there. I can tell you whether you have a medical diagnosis, and I can tell you whether the functioning appears to be as such, but I cannot diagnose. But that information, if you collect all of that, especially if you suspect this before they go to the ophthalmologist, send that with them. Those are excellent tools to give to the physician to say, look, here is a lot of evidence as to why we think this might be going on. And that really, a lot of the physicians appreciate that information, and it helps make their job easier. Characteristics that we look at: light gazing, blink reflex, or visual threat. The blink reflex and response to visual threat, it's either there or it's not. That's not something you can train the child to do. It's just something that we look at. Color, latency, visual novelty, movement, visual fields, visual motor, complexity, and distance viewing. These are the 10 characteristics we'll discuss in more depth this afternoon and what we look at. This is a quote from Dr. James Jan. Due to improved medical care, children with severe brain insults have increasingly begun to survive over the last 30 years. The vast majority have tended to have severe multiple disabilities, including a variety of learning difficulties. A minority of them also has permanent visual loss, but normal or minimally abnormal eye exams. Dr. James Jan is one of the leaders in the field of CVI. He's actually the gentleman who first identified CVI in a population back in the 70s. And it's true. I think the quote's important because we see children surviving at younger ages, when they're at younger gestational ages, because of our technology today. Children who may not have survived 20 years ago because of the technology are today surviving. And very often, because of that, we're seeing children that have a lot more involvement, both medically and physically, in our schools, in our homes, in our communities. And we have the responsibility to provide them with an education and to also provide them the ability to live as normal a life as possible. Traditionally, this is also from Dr. James Jan, traditionally educators for the visually impaired assisted only those whose eye conditions were associated with visual loss. And when we talk about that, we're talking about reduced acuity. Now it has become necessary to offer services to those whose visual loss is due to brain damage. Thus, the definition of cortical visual impairment was born. I think if you talk to many of our TVIs who've been in the system for many years, they'll tell you that this is relatively new in what you see in the classroom. Years ago, a child with CVI would not necessarily have been a student who was on their caseload. But today, we see these children coming into our classrooms, into our schools in amazing numbers. It seems to go up and down, but I can tell you, even just in the early intervention field, which is what I do primarily most of the time, it's been an unusual month. In the last month, I've evaluated 7 children with CVI, and that's just in the small area in which I serve. And that's a very high number for this short period of time. It's been a very busy month. But I can only imagine if that's what we're seeing in our area, you know, that's what you guys have to be seeing in your areas as well. And how many children do we have out there who haven't been diagnosed, who we suspect may have it? Because so often these children are nonverbal. And these aren't the children who come up and say, hey, I'm not seeing things really well, can you help me out? It doesn't really work that way. Now we're going to touch on some of the medical conditions, again, that I breezed over just a few minutes ago that are typically associated with cortical visual impairment. First one is periventricular leukomalacia. When you're looking at a medical report, you may often see that as PVL, is what it may be referred to. One other thing I'll tell you cautiously, when you do look at these medical reports and you discuss them with your parents, try to tread lightly at times, because Although parents may have copies of these medical reports, people may not have sat down with them and discussed what they mean. And not all families take it upon themselves like I would do as a parent. You know, if I get a medical report and I'm going through this medical report and there's something I don't understand, I'm getting on the internet and I'm looking to see what that means. What does PVL mean? What does that mean to my child? But not all people do that. I had a child that did have a diagnosis of PVL and started talking about this condition with PVL and how it's going to limit the brain's growth because fluid-filled cysts don't grow. That the brain tissue grows, but those cysts are just going to expand in size and fluid. That's not usable brain matter. And this parent wasn't even aware that the child had the diagnosis. Or if they were aware, they forgot about it because they were told at such a time that was traumatic with the child being in the NICU. And this was a couple years later. So when you do go over these medical reports, you might want to ask families, what do you know? Tell me what you know about it first and see what they know. And then in a cautious way, if you find that there are holes that they don't understand, try to help get them through that and help them understand what that information means because they do need to understand. Because in some instances, it's not just the services they receive, but it's the resources their child may access for the future as well. Asphyxic hypoxic ischemic encephalopathy. That's a mouthful, but essentially that's just loss of oxygen to the brain. And as a result, you have damaged brain tissue. A CVA or a stroke, brain bleed, and you have the CVA or the stroke that occurs after birth. If they have that brain bleed before birth, then it's referred to as an interventricular hemorrhage. And typically the interventricular hemorrhage or the stroke is what results in the secondary condition of PVL. Because what happens is when you have that brain bleed, the damage from the excess pooling of blood in the brain is so great that it destroys the brain tissue. Now, another condition that you could see that could result in PVL is when you have a child with severe hydrocephalus. If they're born with severe hydrocephalus and they have the excess fluid in the brain and that fluid grows and expands and it starts doing damage to surrounding brain tissue, then you can have destruction of the brain tissue as well. So in terms of an interventricular hemorrhage, it's typically graded 1, 2, 3, and 4. 1 and 2 are relatively mild bleeds. 3 and 4 are more severe. Very often if you do an MRI on a child who's had a grade 1 bleed, if you go back a week, 10 days, 2 weeks later, and they do a repeat MRI, you won't see any evidence of that bleed. The brain reabsorbs the blood, and typically there is very little resulting damage from that type of a bleed. The greater the number, the greater the possibility of damage and the greater the severity of the bleed. So a grade 4 bleed is a pretty significant bleed, and likely if you have a repeat MRI several weeks later, you're going to see resulting damage in that film from that bleed because it was so extensive. Not always the case. There are exceptions to every rule, but I think it's important if you see that come through in a report that you understand what you're reading. You might see associated conditions and associated cortical visual impairment when you have torch infections. One example would be toxoplasmosis. There could be structural abnormalities typically occurring as the baby is developing in utero. One that I see occurring very often in children with CVI, and it's like which comes first, the chicken or the egg. I don't have the medical background or training to say, but very often in children that I see with CVI, I see that they have either a thinning corpus callosum, an absence of a corpus callosum, and that's the white matter in the center of the brain that helps connect the two hemispheres. So I'm not saying that that is causing CVI, or CVI is happening because of that, but for example, that's a structural abnormality of the brain, and very often a lot of the kids I see with CVI have that identified in their medical history. Another structural abnormality that I discussed just a minute ago could be hydrocephalus. And so do you have a child that has hydrocephalus there are some out there who their heads are really not that large, and to be told this child has hydrocephalus, you might be surprised. So if you do have a child that went for a while not being identified and not being treated or having a shunt put in for correction, it there could be some resulting structural damage because of that fluid in the brain. A lot of times ventricles, those are the fluid-filled areas in the brain. Some children have larger ventricles structurally for some reason. Typically these are children that have associated medical conditions. It's not that you and I are walking around with excessively large ventricles, but there may not be anything else identified other than the child has large ventricles. But if they have larger ventricles, then that's going to impact the brain matter, because that is taking up areas where typically there's brain matter. Trauma, we discussed, already discussed a near drowning, head injury. You can have children that could have trauma as a result of getting into, for example, say you have a home where the family doesn't keep their cleaning supplies put away well, and the child drinks something poisoned, and you have resulting trauma. It could be innocent, it could be not. You can't judge that. Shaken baby. I have a little boy I work with right now who's shaken baby, and he was typically developing until the incident occurred. That's a traumatic event. And then we have metabolic conditions. The metabolism of a child is out of sync for one reason or another. It may not have anything to do with anything other than a genetic condition that they were born with. It could be, for example, especially today, the way our society is financially, we all are having to count our pennies. Things are tighter than they used to be. Money doesn't go as far as it used to. And so it's not unusual sometimes to see families who will take the formula and they will water an infant's formula down to make it last longer. There is no malintent whatsoever in doing this. It's simply because they don't have the finances to make that formula last as long as they need to, or to buy more formula, so they're watering it down to make it last. That excess water can lead to metabolic imbalances that can be very traumatic for a child, and often actually can result in death if it's not addressed early enough. So metabolic conditions can result in injury and insult to the brain. Keep in mind there are certain incidents that could fall into more than one category when considering a child's diagnosis and the resulting condition of CVI. And again, an example would be the child who suffered the near drowning, or a child that's born prematurely. They may have multiple medical issues impacting them at one time. It may not just be that they had an interventricular hemorrhage. You may have a child that was a near drowning and as a result had the anoxic incident or the lack of oxygen to the brain, and as a result had damage to brain tissue. So you could have combining factors. Let's talk about some of the myths associated with CVI. Children with CVI are visually inattentive and poorly motivated. This is a myth. They very often appear this way, and if you think about living in the Where's Waldo world, and you're constantly searching, but you can't ever find anything. I know if I'm looking at a Where's Waldo book, 5 minutes tops, and that book is shut and to the side because it absolutely drives me crazy if I can't find it. Well, imagine if you have a child who is living in that, and they're going to be frustrated, they're going to get upset, they're going to get agitated, they're not going to want to participate at times because they're going to simply want to shut that book and sit it to the side. So they're going to look like they're inattentive, and they're going to look like they're poorly motivated. Also, if they're searching, a lot of times you may have those excessive head movements, you know, searching, looking, trying to find something, and it looks like they're trying not to pay attention, or they don't like what you're offering them at that time, when in reality it may be too visually complex. It may be something that they're not ready to handle. So don't assume just because they're inattentive or don't appear to be motivated that they aren't. It could be strictly a result of the CVI. All children with CVI have cognitive deficits. That's not accurate as well. Very often these children appear to have cognitive deficits because if they aren't getting, it's kind of like trash in, trash out. If they don't have good visual information coming in, then they're not going to be able to give you good things coming out, produce good results. Also, if you think about it, like I said earlier, a lot of these children are nonverbal. So it's very difficult if you're working with a nonverbal child to really understand everything that they're taking in if they don't have a way to communicate it back out to you. So keep that in mind. There are a lot of subtle ways that for many of you, you see it every day with the children you work with. You know visually when they're getting something. You know when something connects because it's just like things change. I did an assessment on a little boy yesterday. He's 5 months old, microcephalic. Oh, he has an itty-bitty head. He's probably one of the smallest heads I've seen. He's just, can't tell you how itty-bitty that little head was. But Mom has never seen him look at anything. Never seen him reach for anything. And you could just tell in hearing her story and hearing the story of him, she didn't know that there were going to be issues at birth. Nothing showed up in utero. And you could just hear in the things she said, it was very sad because you could just see everything that she was dealing with. Not sad because this was her child. She clearly loves this little boy with all of her heart, but it wasn't what she expected. And her life is different and his life is different than what they anticipated. And when he looked, and he did look, and it was, to me, it's very exciting. I get emotional, I get excited, but the moment he looked at something yesterday, she's like, he saw that. I was like, yeah, he did. She said, I saw him see that. And he does have the ability. She didn't think he had the ability before that. He hasn't reached, he didn't see, and you could just see a glimmer of hope pop up. And that, to me, is what makes what we do worthwhile. And, you know, she thinks, okay, maybe he's going to be able to do a little more than she initially thought. Is he going to be the next president of the United States? Probably not. But I'm not going to be either. But to give her some hope that there is more in that little head than she thought to start with, you can't take things at face value. And that's one thing that we talk about all the time. The capabilities of our kids, the children we work with, are so far beyond what people judge based on that exterior package so often. So anyway, I can go on and on about that. Another myth, CVI is not a true visual impairment. There's a lot of discussion out there in the field of vision. I don't participate in these discussions. Fortunately, I think that comes from coming into this from a different perspective as an occupational therapist. I miss out on some of that. Probably works against me in some ways, but in other ways I'm kind of detached. But there is a lot of discussion out there in different camps as to whether or not this is truly a visual impairment or truly not a visual impairment. You know, to me, one way or another, it affects the vision. So whether or not it has to do with the eye or not, whether it's the brain or the eye, it impacts what that child does and how they perform. Is it truly something happening in their eye? No. But is their brain impairing what they see and how they perform? Yes. So in the end, as long as we can help them, I think that is what matters the most. Children whose visual cortex is damaged are cortically blind. There's a lot of other discussion that goes on about this, and I think our TVIs probably are much better voice to speak about this. The one thing I can tell you that I see in the children and adults that we work with, old school thinking of the brain is it's compartmentalized. You have the frontal lobe, temporal lobe, parietal lobe, occipital lobe. This lobe does this lobe does that. This lobe does this lobe does that. You damage this lobe, you damage the occipital lobe, vision's gone. You damage the frontal lobe, boy, the emotions, control, that's out the window. But I think what we're seeing is technology advances, and as we work with more and more people today, that is not the case anymore. These centers of the brain may be the primary operating areas of these functions of our body, but what we're seeing is that when trauma occurs, when injury occurs, is that other areas of the brain are picking up function. And a perfect example is a child who's had a lobectomy. You see a child who's had part of their brain removed for whatever reason, seizures, injury. I have a little boy who had a tumor who just had part of his frontal and parietal lobes removed. Well, if you go with old school science, based on that, if that part of the brain is gone, then whatever functions those areas controlled, they're gone too. You don't get those back. But if you think about a stroke patient, somebody in their 60s who's had a stroke, who has totally blown out that area of the brain, you know it's not coming back. It's gone, it's damaged. And you tell them they're never going to use the right side of their body again. But lo and behold, 12 months later, they've been doing rehab, they've been working very hard, and they've got some movement of that right arm. Well, that area of the brain did not repair itself. Brain tissue does not regenerate, just like spinal cord tissue does not regenerate. It doesn't grow back. Somewhere, somehow, new pathways have been formed and something else has picked that up. It may not be as good as the other areas, it may not work, but what technology is finding today is that our brain is rerouting communication pathways, and other areas are starting to pick up functions that may not have been associated with them before. So I think that's important to keep in mind. Now we'll talk about some truth. Treatment is educational, not medical. That is a truth. That is one difference between an ocular and a visual condition. With ocular conditions, very often you correct those with glasses or with surgery, or I think that's probably my only two options. TVIs, that's pretty much the only two options, I think. You can use assistive technology in the classroom to help modify environments, but cortical visual impairment is not that. If we're talking truly CVI, you can't stick a pair of glasses on it and fix it. You can't do surgery and fix it. So treatment is educational. You're retraining the brain. You're developing new visual pathways. I don't think people really think a lot about it, but when you're working with a child with CVI or really any neurological condition, when you're working with them and instructing them, and I don't think about it on a regular basis, but it's pretty amazing because you're altering their central nervous system. That's what you're doing. You are making permanent, lasting changes in their central nervous system. That's pretty amazing. I mean, when you really, really think about it, you're making things that are going to go with this child. So try to make good changes because they don't really want the bad ones so much. Visual functioning fluctuates depending on environmental factors, time of day, health of the child. That's a truth. You may see a child visually do something one day and you come back in the next day and they don't do it again. And you're like, why are you not doing this? You did it yesterday. Why are you not doing it today? Something could be different. It could be the clothes they're wearing. They might be wearing something that's really uncomfortable and so they can't focus. Something in the room could be different. You could be presenting the item a different way, so visual functioning does fluctuate on a day-to-day basis. They might be sick and they may not feel good. CVI may range from mild to severe. That's a truth. And the one thing that I've been very fortunate, knock on wood, up until this point in all the children I've worked with, is I've been able to see an improvement in their visual functioning. How much varies from child to child. But I can say I've been very blessed that I have seen something positive happen with every child I've had the good fortune to have access to. Is that always the case? I don't know, because I've just got the limited number of children I've been exposed to. But it's been a blessing so far. Intervention strategies center on the resolution of the CVI characteristics. When we talk about working with the children with cortical visual impairment, what you look at when you look at structuring the strategies and the implementation of strategies and treatment that you're going to do with them is you're going to focus those on the 10 characteristics that we talk about. That's how you're going to structure what you do with these kids. You're going to look at what they're doing with each of these characteristics, and that's how you're going to make your choices and decisions as to how you're going to change what they're working with, what they're doing, how their environment is. It's like a roadmap. And once you figure out how that roadmap works, it really serves as a good guide to you. And it's a wonderful tool to work with. It's been proven that the first years of life are when the brain is most plastic. This is not something that's suspected. This is something based in science, research, and fact. From 0 to 7 is when it's found that the brain is most plastic. That's when you can implement the most change on it. That's when you can have the greatest impact. Does that mean after the age of 7 you mark them off and say, well, they're not young anymore, that brain's not plastic, can't help them? No, because if that would be the case, then we wouldn't rehab people who've had strokes in their 60s or 70s. Doesn't mean they can't still learn, doesn't mean we can't make changes. But the key to this is the earlier we can get these kids active and involved with TVIs, with Insight, with teams that actively address CVI as part of the routine, families who involve vision in all aspects of these children's days, the better the results hopefully will be. And I do have to say, again, and again, I'll use a lot of personal experiences, but the personal experiences of the children I've worked with, the ones that we start seeing earlier, 3 months, 4 months, the progress that they make, it just seems almost at light speed at times. I mean, by the time they're 3 and they're transitioning into the school system, we're looking at children that, for the most part, in many instances, are showing typical visual responses for a child their age. Does that mean the CVI is resolved? No, and that's a sticking point with me that I'll discuss later today. They look good, but the issues at that point when we get into what's called phase 3 of resolution is more when we get into those literacy issues. And although they look really, really good for functional vision, for getting around in their environment, for going and playing with toys and doing this, that, and the other, doesn't necessarily mean everything's a-okay. But very often, you know, at the age of 3, they're doing what a 3-year-old should do, and they look great. The problem comes when they hit you guys in the school system a little bit later on, and some of those things start coming back out. But very often they're misdiagnosed as learning disabilities, mild MR, autism. They're not necessarily identified for the relationship it may have to vision, which was identified years earlier. So that's another reason I advocate for getting those medical reports. You might have a child that transitions from birth to 3 into the school system. They look really good at the age of 3, typical visual responses, don't qualify for preschool developmentally delayed, so they hang out at home for a couple years, go to Head Start, hit kindergarten, start having issues. You don't have access to a medical report that clearly identifies at birth they had an interventricular hemorrhage, had a diagnosis of CVI with no secondary ocular condition, but at 3 they looked really, really good. And you've missed a huge, huge piece of valuable information that could change that child's educational program for years to come. So again, back to the medical thing. And that also goes along with children with CVI are misdiagnosed. Very often these children are misdiagnosed. I'm planning to participate in the webinar on CVI and autism because I can see in many of the autistic children I work with a lot of similar characteristics to some of these kids with CVI, especially who are nonverbal. They sure do look a lot alike. And how do you tease out? How do you tease that piece out? Because if you don't have a secondary ocular condition, it very well could be autism. And at the rates autism is growing in this country, we are encompassing huge, huge numbers of children. And with the fact that we're dealing with cortical visual impairment, that's the fastest growing ocular or eye impairment in the country, you know, these roads are going to clash at times. And so it's going to be up to you guys to figure that out and help families make sense and see which paths they need to travel. When we're back to the assessment framework, again, we're looking at the medical diagnosis. Parent interviews are critical because the parents will give you valuable information that may not be in the medical report as well. And when we're doing assessments or getting to know these kids, they may give you pieces of valuable information that they don't even know they're giving you, like Johnny loves red. His favorite color is red. He looks at anything red. Well, there's a light bulb. Okay, clearly Johnny's noticing red, so that may give you a place to start. Parents have so much valuable information. They are just a wonderful resource that we need to get as much out of as we can. Observation. Take time to sit and watch the child. You know, structure. First, see what they do in the environment when it's not structured, and then, you know, give them some structure, see what things change. Don't take things on face value. The assessment of the characteristics and sharing results with family and team members. There's nothing to gain in us keeping information from families, and that's why I say be careful when you first look at the medical reports, because families may not really know everything to start with, but they need to. They are the one who's going to be the advocate for their children for years to come. When we've come and gone, they're still going to be there. They're the ones who are going to advocate to see that these children get the services they need. They may move. They need to know what's going on with their child to make a difference in their lives at home on a daily basis. Again, I discussed that intervention centers on the resolution of the characteristics, which is what we'll get into a little bit later. And that ends section 1 of the handouts.